A single cellular copying error occurs in the human body thousands of times a day. Most are caught and repaired. But when a mutated cell ignores its programmed stop signals, begins to aggressively multiply, and physically breaches local tissue boundaries, a localized error becomes a lethal systemic threat. This process is neoplasia. By definition, it is the abnormal, uncontrolled proliferation of cells, driven entirely by specific genetic mutations. The clinical presentation depends on the exact nature of those mutations. Benign tumors grow slowly, remain encapsulated, and are strictly localized. Malignant tumors acquire the specific biochemical tools required to invade surrounding physiological structures and metastasize to distant organs. Mastering board-level oncology requires moving beyond memorizing disjointed symptoms. You must connect microscopic genetic triggers directly to macroscopic anatomical spread. Cancer is a predictable biomechanical cascade. We can trace its path from the initial DNA insult to systemic organ failure. Every tumor begins with structural damage to the DNA that regulates the cell cycle. This chart shows the two-hit requirement for tumor growth. The first hit is a gain-of-function mutation in a proto-oncogene, genes like RAS or MYC, that normally promote healthy cell division. When mutated, the cellular accelerator is stuck permanently in the on position. The second hit requires a loss-of-function mutation in the tumor suppressor genes. These are the brakes of the cell, such as TP53 and RB. Without them, the cell loses all capacity to halt division or trigger apoptosis, and the system spins rapidly out of control. These DNA mutations do not occur in a vacuum. Specific environmental and chemical carcinogens damage genes in highly predictable patterns, leading to localized cancers. Populations consuming high amounts of nitrosamines, found heavily in smoked, preserved, and salted foods, show distinctly elevated rates of gastric carcinoma. Industrial exposure to airborne asbestos fibers directly damages pleural and pulmonary tissue, causing mesothelioma. When combined with smoking, the risk of developing bronchogenic lung carcinoma multiplies exponentially. Other high-yield chemical associations include aflatoxin, produced by Aspergillus species in improperly stored grains, which mutates the p53 gene and causes hepatocellular carcinoma. Vinyl chloride, used in PVC manufacturing, is the direct trigger for hepatic angiosarcoma. Viral pathogens also hijack the host's genetic machinery. High-risk strains of HPV, specifically types 16 and 18, are the primary drivers of cervical carcinoma. The Epstein-Barr virus is heavily linked to both Burkitt lymphoma and nasopharyngeal carcinoma. Genetic mutations are the specific, inevitable footprints left behind by distinct environmental and viral insults. Once the cell cycle is hijacked, the growing tumor mass must physically break out of its home tissue to become lethal. This animation illustrates the first mechanical step of invasion. The tumor cells downregulate E-cadherin, a surface protein responsible for cell-to-cell adhesion. The cells lose their contact inhibition, detach from their neighbors, and prepare to migrate. The point of no return occurs when these rogue cells secrete matrix metalloproteinases, or MMPs. These enzymes actively degrade the extracellular matrix and chew directly through the basement membrane. Once the basement membrane is breached, the tumor enters the vascular and lymphatic systems. The cardinal rule of metastasis is straightforward. Epithelial malignancies, known as carcinomas, typically spread via the lymphatic system. Connective tissue malignancies, or sarcomas, spread hematogenously through the bloodstream. 4 specific carcinomas bypass the lymphatics and spread directly through the blood. You must memorize these exceptions: follicular carcinoma of the thyroid, choriocarcinoma, renal cell carcinoma, and hepatocellular carcinoma. When metastasis reaches the bone, the resulting damage depends on the tumor's origin. Breast carcinoma typically causes osteolytic lesions, actively destroying bone tissue and releasing massive amounts of calcium into the blood. Prostate carcinoma creates osteoblastic lesions, depositing abnormal sclerotic bone tissue. A tumor's lethality relies entirely on its mechanical ability to breach the basement membrane. Until those enzymes cross that boundary, the mass remains entirely in situ. Malignant tumors often act as rogue endocrine glands. They secrete ectopic hormones and cytokines, causing systemic symptoms that run in parallel with the tumor's physical growth. These are paraneoplastic syndromes. Small cell lung carcinoma is the master of these endocrinopathies. It aggressively secretes ectopic hormones, causing SIADH, which leads to dilutional hyponatremia, and producing excess ACTH, resulting in Cushing syndrome. Small cell lung cancer also generates antibodies against voltage-gated calcium channels, causing Lambert-Eaton syndrome, where muscle weakness improves with repeated use. Contrast this with thymoma, which generates autoantibodies against acetylcholine receptors, causing myasthenia gravis, where muscle weakness actively worsens with use. Squamous cell carcinoma of the lung has its own signature paraneoplastic weapon, the secretion of parathyroid hormone-related peptide, or PTHrP. This directly strips calcium from the bones, causing severe hypercalcemia. Tumors of the kidney and liver, specifically renal cell carcinoma and hepatocellular carcinoma, can ectopically produce erythropoietin. This continuously stimulates the bone marrow, resulting in a dangerous overproduction of red blood cells, known as polycythemia. Internal visceral malignancies frequently manifest as sudden dermatological markers. Gastric carcinoma is strongly associated with acanthosis nigricans, hyperpigmented velvety plaques on the neck and axilla, and the Leser treilauxine, the explosive, sudden onset of dozens of seborrhea keratoses on the skin. Paraneoplastic syndromes transform a physically isolated mass into a body-wide metabolic saboteur. This chart highlights the epidemiological split between incidence and mortality. While prostate cancer in men and breast cancer in women boast the highest overall incidence rates, lung cancer dwarfs both to claim the highest absolute mortality across both demographics. To assess the threat of an individual tumor, pathologists utilize two distinct metrics. Grading is the microscopic evaluation of the tumor cells themselves, measuring the degree of cellular differentiation, pleomorphism, and the rate of mitotic activity. Staging evaluates the macroscopic physical spread of the disease using the TNM system, T for primary tumor size and local invasion, N for regional lymph node involvement, and M for distant metastases. A highly aggressive, poorly differentiated cell grade means very little if the tumor is small and entirely localized. Conversely, a low-grade, well-differentiated tumor that has already spread to the liver is a catastrophic threat. For board questions regarding patient prognosis, TNM staging universally overrules grading. Blood tests measuring tumor markers, like CEA for colorectal cancer, CA-125 for ovarian cancer, and AFP for hepatocellular carcinoma, are excellent tools for monitoring treatment efficacy and checking for recurrence. They are not used for initial diagnosis. A tissue biopsy remains the absolute gold standard for diagnosis. It confirms the cellular origin and informs treatment strategy, dictating whether a patient will face standard chemotherapy or targeted radiation for highly radiosensitive tumors, like seminomas. Microscopic grading shows what a tumor looks like. Macroscopic staging dictates if the patient survives it. Let's consolidate the highest yield associations required for NRE board mastery. Look at this matrix. Carcinomas strictly spread through the lymphatics. Sarcomas strictly spread through the blood. The four major exceptions that mimic sarcomas are renal cell, hepatocellular, follicular thyroid, and choriocarcinoma. For carcinogens, asbestos exposure heavily correlates to mesothelioma and lung carcinoma. Aflatoxin ingestion maps directly to hepatocellular carcinoma. For paraneoplastic syndromes, small cell lung carcinoma triggers the endocrine triad of SIADH, Cushing, and Lambert-Eaton. Squamous cell lung carcinoma secretes PTHrP, driving up serum calcium. And the ultimate prognostic law, staging always dictates patient survival over grading. In clinical pathology, chaos is an illusion. Every systemic failure begins with a highly specific, localized defect. Master the mechanisms, trace the pathways, and the correct diagnostic answers will reveal themselves.